Good day, everyone. This is Tim Richter, President of the Canadian Alliance to End Homelessness. Welcome to our webinar today with our friends from Médecins Sans Frontières on management considerations for COVID-19 positive clients experiencing homelessness. Today's webinar has the same format as all of our other webinars. We have a brief introduction, which is what we're doing right now. We have a presentation and a question and answer period. I'd ask that everybody, please feel free to use the chat function to chat with your colleagues. I know some of our presenters may be posing questions to you in the chat function, and make sure that you are sending a message to all panelists and attendees. Please use the Q&A tab to ask questions. That allows us to moderate the question and answer period at the end. Just so you know, we're going to have the webinar recording posted at on the CNH3 website at the address listed below. That's a Canadian Network for Health and Housing of People Experiencing Homelessness. And there you will also find a pile of resources that we've been collecting on COVID-19, supporting your response to the pandemic. I'm now pleased to introduce our speakers. We have Jaime, who is the medical lead with Médecins Sans Frontières at Doctors Without Borders and the Canadian COVID-19 response team. We also have Dr. Kate Hayman and Dr. Leslie Shanks. And with that, I am going to stop share and pass it over to them, and over to you.
Perfect. Thanks so much for having us. So yeah, we wanted just to give a little bit of an overview of who we are, what we're doing. So Doctors Without Borders, or in French, Médecins Sans Frontières, is an international emergency medical humanitarian organization with a mission to provide life-saving medical care to those who need it most. Our activities are mostly international. We focus on 4 areas. First is lack of access to healthcare, so places like the remote areas of the Democratic Republic of Congo. We also operate in situations of violence and conflict, such as areas such as Syria, natural disasters, including earthquakes, typhoons, hurricanes, and epidemics, such as Ebola and now the COVID outbreak, which is now a pandemic. We're operational in 72 countries, but that number has drastically increased now with this COVID response in many areas around the world where we normally don't see, our response because of most countries have an advanced healthcare system. So places like the USA and Italy now have operations there. So our international operations really want to focus on areas, especially areas where the current medical systems are overwhelmed, or where the basic health systems are extremely basic, in areas such as South Sudan, where you only have about a handful of ventilators for the population. As well as, places where there's a lot of overcrowding, where social distancing is not possible, such as refugee camps in Bangladesh. But then also that there's a continued, the situation, what we call the everyday emergency, is still present in many places around the world. So areas of conflict, where disease is rampant and where there's a lot of malnutrition. So MSF continues to want to have a presence in these areas, even throughout the COVID outbreak. In Canada, it's quite exceptional with what we're doing. We started with a small team just to try to evaluate what the needs are and whether or not we needed to have an operational presence here in Canada. We first identified vulnerable groups, including the elderly, people experiencing homelessness, refugee claimants, incarcerated populations in prisons, Indigenous populations, especially those living in remote and isolated areas. And early on, we got in contact with an organization called the Inner City Health Associates, who are a medical organization focusing on providing medical care to people experiencing homelessness. And this is where we got in touch with Kate and Leslie, who are also MSF field workers, but also working with this population. So today we just wanted to, share our experience, more importantly, their experience, working with this population, especially COVID positive populations, and share more pretty much what they've experienced and some reflections on their end. There might be more questions than answers at the end of this, but the idea is to have a dialogue and to share kind of these experiences. So we have two people here. We have Kate, who's an emergency physician. She's the co-medical lead for the downtown Toronto COVID positive recovery site. With Inner City Health Associates. She's a field worker, and she would have been in South Sudan, but she's here with us now. And then we have Leslie Shanks, who's a family physician trained in public health. She joined MSF, Doctors Without Borders, in 1994 and has worked in various positions within the organization, both in the field and in headquarters. She's practicing family medicine in Toronto, and her practice involves supporting people experiencing homelessness. So with that, I will hand it over first to Kate, who will first share her experience.
All right, I'm going to unmute myself. Can you hear me okay, Jamie? Okay, so I'm going to speak a little bit about the COVID recovery site program. And so I'm speaking today both as someone who's worked with MSF and also as a member of Inner City Health Associates. ICHA is a group of physicians that has been working to support people experiencing homelessness in Toronto since 2005, a group of over 100 docs, and since the beginning of the COVID crisis has really expanded and now has more than 70 nurses also as part of the team. And the vision for ICHA is a healthy end to homelessness. Together with multiple community partners, including the City of Toronto and the University Health Network, we have been operating since early April, one site for folks who have COVID to recover, and just since Saturday, got our second site up off the ground. And the objective is to allow people who are experiencing homelessness, who have been diagnosed with COVID, a place to self-isolate with some supports. And it is not intended to replace hospital care. So people experiencing homelessness who require hospital level care absolutely should still be getting it under this model. And the philosophy of care really is to provide a dignified place for recovery from COVID and to support people's isolation as best possible, recognizing that people have very diverse needs. And there's a real focus on social and psychological needs and utilizing a lot of the knowledge brought by peer workers and people with lived experience. Our clients have been, many of them have had a very positive experience coming from the site. We've got a thank you letter up, and also for the nurses, this has provided some unique opportunities. And also for the physician group, it's a really sort of unique and new model where we have community resources and physician resources and nursing resources quite closely integrated in a way that is quite different than what happens in acute care normally. So I'm going to speak about some of the specifics, and as I do that, really recognizing that this is quite an uncommon program, and many folks are working in communities where a site like this is not accessible, and even here in Toronto, the site is not necessarily accessible to every member of the population who is experiencing homelessness. And so really, I hope that for some of the folks on the call, this can be an opportunity for learning bits and pieces that could be taken away and applied to your own context. So folks that are supported at the site are people who are experiencing homelessness under quite a broad definition, have a confirmed COVID diagnosis, don't require admission to the hospital, and are able to isolate independently in a room for 14 days, which means that some people that have very high behavioral needs potentially cannot be safely supported at the site because folks are going to be in a hotel room, closed door, and really need to call for assistance if needed. Our physical site is an airport hotel. It looks similar, although not identical, to the hotel room that I'm sitting in right now. We've got 173 rooms that support individuals, and then clients who are there with family members are also supported in a room together if there isn't a safe space for family members to stay. So for example, moms with newborn babies. And we have this big interagency staffing model, which has involved a lot of learning for all of the members involved, and it's designed to accommodate fluctuations. Although, as you can imagine, when there are many additional folks who receive a COVID diagnosis at the same time, it can be challenging to accommodate big fluctuations simultaneously. And in many ways, it's a lot easier for the intake team if we have kind of a small group of clients arriving at the same time. In terms of infection prevention and control, there's a lot of specificity, but one of the really important things is that we have designated pathways throughout the building. We've actually just changed our language on this, so we're calling them hot and cold, which is preferred so that we're not implicating that any of our service users require sort of dirty pathways only, but having really clear areas where you wear PPE in some areas, and then the clients who have COVID are in those areas with staff members wearing appropriate PPE. Our cleaners have had training from hospital staff, so they're able to provide hospital level cleaning, and we have PPE provided for staff that are used for client interactions. One thing that's really helpful for staff is they do have access to uniforms, so scrub service and showers. And the clients are primarily encouraged to stay in their rooms and are accompanied by staff when they go outside. Having IPAC support has been really helpful, both in terms of ensuring staff comfort and safety. And also, while we're working in a COVID environment, of course, COVID is not the only thing around. So ensuring that we have good IPAC procedures in place also helps to prevent outbreaks of anything else infectious, which pops up from time to time in shelters. And we have also had intermittent voluntary COVID testing for all workers at the recovery site to help as a staff outbreak management tool, and to ensure that we don't have anything going on that we're not aware of. So the medical piece of this, I'm speaking as a doctor, but the medical piece of this is probably the smallest part of what's going on. We do have a 24/7 nursing team on site, and most of the issues that arise, some of them are related to COVID deterioration, but a lot of it is actually related to the challenges of being isolated for 14 days, or to people we're trying to avoid things like visits to a primary care provider, because the clients have COVID, and so transfers are a little bit tricky. So this is really about supporting people medically on site as much as possible. We do have a doc on site during daytime hours, and then on-call support after hours. And I recognize this is a much more medicalized model than in most other contexts. We have psychosocial supports, as I mentioned, which is a big piece of things, and a lot of that is support around discharge planning. Our clients have been really concerned about potentially going back to a space that has an outbreak, which people are not being discharged back into that scenario, but there's a lot of anxiety about it, and a lot of anxiety about the stigma of the diagnosis, and how will people be treated when they get back to their home space. Most of our clients, fortunately, have been able to be discharged into hotel programs. We have quite robust substance use supports, which includes a managed alcohol program, provision of cigarettes, and peer supports around injection drug use, as well as clean kit and naloxone. And we are trying hard to connect people on discharge, but as you can imagine, for some folks, they may have access to the managed alcohol program while they're on site with us, but there are relatively few managed alcohol programs out in the community. So getting them in touch with adequate supports on discharge is not always as seamless as we might hope. Clients are provided with food and snacks, which is important so that they're not keen to go out and get other stuff. Although clients have been able to order food in, which happens from time to time if they have means and they have a want for something else. We've had some challenges in terms of water, because a lot of folks are more comfortable drinking bottled water. So that's something that we've been aiming to provide, because it's really important that people stay well hydrated while they've got COVID, and really encouraging people to eat and drink adequately, because particularly for clients who have lost their sense of taste or smell, which can happen with COVID-19. They often don't have a lot of appetite, so we're trying to encourage staff to encourage clients to take stuff in. And as mentioned, discharge planning is a big piece of what happens when people come to the site. We try to start the discharge planning process very early and really try to notify people of their tentative discharge date as soon as possible so that people have a chance to prepare for the fact that they're going back somewhere else. And we also provide a letter to the shelter explaining that the client has recovered from COVID on discharge so that there are no questions on the receiving end about whether the person potentially poses a risk to the other clients on site. And we also aim to connect people to primary care if possible and if they're not already connected. A pretty quick oversight, and again, recognizing that this program hopefully can provide bits and pieces that might be informative to other contexts. I'm happy to answer any questions specifically to the COVID recovery site program or to answer questions at the end.
Great. I don't see any questions yet. So why don't we go ahead and we'll move forward with Leslie's presentation. And then maybe we'll catch all the questions at the end, so I don't see any here.
All right. Well, thanks, Jaime, for passing it over, and Kate for the excellent talk. I'm going to be talking to you now about a strategy for managing COVID-19 positive individuals in a group living or congregate setting. And I'm going to use a case study of an outbreak to illustrate my points and try and offer some recommendations that have come out of that experience. I think it's important to say that I'm giving you my personal perspective now as a community physician who arrived on the scene to try and assist the shelter management team and clients to deal with this very difficult outbreak. Before I get started, though, I'm very curious to know how many of you in your settings have had to manage someone or a group of people who's positive with COVID-19 already in your setting, and what were the circumstances around that? And perhaps you could use the chat to share that with us. And meanwhile, I will try and make my screen share. There we go. Okay, so talking first about when would the situation arrive that you need to keep somebody in place who's COVID-19 positive. In some cases, it will simply be the easiest and simplest way to manage one person or a small number of mildly symptomatic people who are in your setting, particularly if you have single rooms. In other cases, it may be the only solution possible given the lack of other options or a system that's overrun with cases. One thing that I do want to stress, though, and why I think this topic is particularly pertinent right now, is that I think we all recognize that there's a huge need right now to increase our testing and to do mass testing in shelters. That's very clear in the US. You can see these articles. I don't know how many of you saw the article in Nature, which also strongly recommends mass testing in shelters. But all of the studies that have been published or experiences that have been published in the US are recommending that there is consideration of early mass testing in shelters. So doing that means we are going to have to deal with these COVID positive cases and have a plan to deal with them. So let's turn now to the case study at hand. This took place at Willowdale Welcome Center in Toronto or North York. It's run by Homes First Society here. It opened last November and supports over 200 refugees and refugee claimants with shelter services, connecting them with housing opportunities and work opportunities, and also provides a very strong social network for people who are newly arrived in Canada. As you can see, it's located in a very large, it's 800,000, so 80,000 square feet. It's a former office building. So this is not what situation I'm more used to, a very crowded shelter situation. As you can see, it has a nice open setup. There's the upper floor where the women are housed, and the lower floor for the men. There's also a large dining room, recreation areas, etc. More recently, after the pandemic started, there has been another shelter created in a separate section of the building. This is called, rather unimaginatively, Building B, and it shelters 45 men who've been relocated from their previous shelters in an effort to decongest the shelter system. So you can see here that, again, the beds are appropriately spaced. There's, in this case, 3 dividers on 3 sides of the beds to try and provide some protection. The outbreak that caused us to cohort and place so many people was first alerted in the media in early April. You can see these are some of the media reports. In fact, the first case probably started back in March. But this is how I found out about it and became involved. I read some of these media reports about the outbreak, reached out to the CEO of Homes First Society and asked whether she needed any help. She was very quick to tell me exactly what was needed, which was more testing. And so I offered to go in, do an assessment and see what I could do in terms of the testing. At that point, we had very clear direction that we were not to be testing anyone who was asymptomatic, but only symptomatic. I saw 12 people the first afternoon I was there. 8 of those were symptomatic, and I tested all of them. We were all collectively very, very concerned about the situation in the shelter, and I was very fortunate that after I came in and had some discussions with Toronto Public Health and the ongoing, I think, pressure to try and do more testing there, that very quickly got the okay from the province and then through Toronto Public Health that we could do some mass testing. So within 24 hours of running that very short clinic, we had a SWAT team from North York General ready to come in and swab everyone in the building. And they were fantastic in getting that organized very quickly. We planned to test everyone, whether or not they had symptoms, to offer the testing to staff. And we also decided to test Building B, even though it was physically separate from the newcomers, but given it was on the same site, we felt that it would be important to do that as well. Of course, before the testing, we coordinated with Inner City Health Associates who are running the COVID response center with the city to let them know that there could be a surge in cases who needed to be relocated, either because they needed to be isolated as direct contacts or because they were positive. So we felt that we had at least a semblance of we had a plan in place and a legitimate plan for the positive results. So we did the tests on Friday. Sunday afternoon, the results started to trickle in. There were a lot of positives in that first bunch. I thought maybe it was just the way they'd grouped the results, but they kept coming in positive. And by the end of that time, we had 70 positives, and we'd only had less than half of the results in. Needless to say, the numbers were very shocking for myself and for others. I think we had heard of the Boston shelter outbreak where they had over 30% positive. So we were prepared. Worst case scenario, it might be as high as that, but we certainly were not prepared for what we had then, and what we ended up with was 70% positives. So we had an emergency meeting that Sunday evening. You can imagine there were a lot of people on that call, a lot of people very concerned. What do we do with all of these positive people? How do we manage the situation? There was an initial decision to move people out to the COVID response center, etc. However, overnight that option was closed to us. So when I went in on Monday to start delivering the results, I heard that we were now having to cohort everyone in place. So that was quite a challenge. Now, let me just review briefly for you the results so you know what we were looking at in terms of having to find space and manage the people there. So the building B, again, these are people from the more traditional shelter population who have been relocated for improved infection control. They, I think very sadly, were over 60% positive. The men were particularly hit, and it was this where it was felt the outbreak started. 87%, I think the people who weren't positive there were people who had already cleared it, just given the timing. Women did a little better than the men in the newcomers center, but again, pretty high numbers there. Important to note, however, that most people were actually quite healthy. At the end, we had just over 50% of people who were entirely symptomatic, and others just had very mild symptoms. So this is how we decided to deal with those individuals that those numbers represent. This side of the building here, if you can see my pointer, was where the 45 men had come from the shelter decongestion. We decided to move those off to the COVID response center, and the people who had tested negative to be isolated for 14 days because they had obviously been in close contact with all of those positives. So that freed up that site, and we were then able to move the 40 women who were tested negative but were still at high risk of developing disease because of their massive exposure. That left us in the main building with 86 positive women and 45 positive men. So we had a COVID positive section and a separate COVID negative or close contact section. Each section had its own entrance, its own bathroom, showers, meal areas, recreation areas. So in that sense, we were very fortunate to have all of that space to play with, and it was quite easy to adapt it to these because in fact, the two sites had already been running quite separately. Now that we had a plan as to where to move people, our priority was really then to give people their results. Fortunately, I was joined at that time because I was the only healthcare worker there. I was joined by the physician who generally runs a weekly clinic in the site, and when he had heard the results, he offered to come in and help me, and that was a huge help because we had to meet with all of those 260 people who we had tested and let a large portion of people know that they were positive, and help them deal with that news because obviously there was a lot of anxiety associated with that. Do a very quick triage and assessment to see if they were stable to remain in the shelter, and also try and assess whether they were at risk of developing complications there. So there were some individuals that we identified in those coming days that we did ask to be negotiate with the COVID response center to see if we could move them over there, just because we felt that they were at higher risk. I think we were pretty clear that this was was nowhere near the level of a COVID response center. We should really only be having people who had very mild symptoms and that were at low risk of developing any complications, just because the lack of any facilities and to deal with it at that point. So we really tried to err on the side of caution where we were able to find placements for people. So as you can imagine, having this situation develop so rapidly created a number of challenges. One of the really key challenges, and I think is pretty much to be expected for a situation like this, is the lack of staffing. And the word I kept hearing when I came into the shelter was decimated. So many of the full-time shelter staff were either sick or were off because they were completely exhausted or afraid to come in. This meant, of course, more agency staff, more part-time people who did not have the same familiarity. And we particularly felt the lack of supervisors because we were down really to one supervisor who was still able to work. So really critical to this success of the operation that we were implementing that week was the arrival of 2 senior managers from Homes First headquarters who stayed on site for the majority of that first week and provided huge support to the team in place. And without that, it would not have been possible. One of the main priorities was finding nursing staff, because there were no nursing staff, of course, in the shelter. Nursing staff are not that easy to find during a pandemic, and probably a little harder to find when you're offering them a very short-term position in a shelter that's just had a very large outbreak. Fortunately, however, by about 7 days after the testing, the first nurse did arrive. I have to say, I don't think she will forget her orientation that evening. She was expecting more of a COVID response center, and instead she found, of course, a shelter, except a shelter where all of the residents and clients were positive for COVID. So we spent some time chatting about that and what that would mean and what her role would be. And she rose to the occasion, as did all the others, and very quickly became familiar with a different way of working there. One thing that was really important for the healthcare staff was to be monitoring the negatives who were close contacts, to make sure that as soon as anyone was showing symptoms, that they would be tested and then moved out to be isolated. We didn't want to have new cases appearing amongst the women that were negative, because it would then mean that they would have to again be isolated for another 2 weeks. The other thing was really monitoring symptoms in other people again, so we could identify very early people who needed to leave the shelter and go to a more appropriate place, either COVID positive response center or to the hospital. So this was really very good news once we had a 24/7 rota of nurses. Other challenges, as you can imagine, was the infection prevention and control. This again was challenged by the huge turnover of the staff, but also having the expertise to do this. This is not easy to implement and to understand what is the standard needed for IPAC in such a setting. It's not a healthcare setting, it is a shelter setting, but how do you manage when you have turned it effectively into a shelter of COVID positive individuals, and actually where the infection control risks were more concerned, the COVID negative, where people were at risk of developing COVID-19. So this was really a challenge and needed a lot of attention from the managers. I think it's important, as we talk about all the challenges that faced us as we were trying to sort this out, is the many challenges that were faced by the residents and the clients, both coping with the news and all the anxiety that brought with it. Even if you were negative, you didn't feel like you were out of the woods yet, because you realized that you still had, it was still very possible that you could become positive in the coming week. But one of the really difficult things was, because of all the media attention, people were looking for housing and work opportunities. Some of them were already working. And as soon as people saw their address, the doors would be closed, particularly for housing. Many people told me that they lost their housing opportunities as soon as the address was read by the landlord. So this was really difficult for the people in the residence. In order to help with that, communication, of course, is huge. This was something, again, is a challenge when you can't bring people together to discuss with them together. We ended up doing a lot of one-on-one. The fact that my colleague and I were present, really long days in the beginning was helpful, so people would come up to us, ask their questions related to health, etc. There were also a myriad of health-related practical issues. Just, you need Tylenol. People have headaches, they feel achy, they're unwell, some of them. You need to be able to get over-the-counter medication. People need cigarettes, and if not, they're going to leave the building. They're all supposed to be quarantined. Wi-Fi, people need Wi-Fi. If you're going to lock them in a building, they need Wi-Fi, they need TVs, all of those things. Very practical, but really important to people's ability to stay quarantined and to manage what is a very difficult situation for everyone. And one challenge that I hadn't anticipated was that of tracing people. And by tracing, as I'm talking about the contact tracing, and also just getting people the notification of results. It's quite a mobile place, of course, with the outbreak going on. That really, a lot of people were trying their best to move out. So some people were difficult to find by the time the results came through. Not many, but some were. And the other thing was that for public health, they needed to get in touch with everyone to do the contact tracing. And it was difficult for them without phone numbers. And remember, nobody here had OHIP numbers, so they weren't able to get any contact information there. What they decided to do at public health was they actually came on site and brought phones for people to use. So people would come up to them after they got their results. They would be given a phone. They could then go and sit in a corner, which was relatively private, speak at a physically in a physically distant setting to the person who was just at the table around the corner, but that then allowed them to do some direct education to them and to do the contact tracing. Because remember, people out here were very much in the community. Some of them were working. There was a lot of contact tracing that needed to be done. So, recommendations, and these are really just the things that, coming from this experience, that and also of course from the outbreaks that I've done over the years with MSF, my advice would really be to make sure, if you don't already, have somebody who's in charge of IPAC. I think in medical settings that always happens, but then we're medical people, and that's part of our training. In a shelter setting, you very often won't have somebody who is from a medical background, and it will be asking someone to do that, to be responsible as part of their regular job description. But having somebody responsible and doing that now, I think, will make a huge difference in how things are implemented, and will allow them to get some training, so that if you do end up having to manage COVID positive people in your site, or perhaps you're doing that already, there is one person who's overall responsible for that. Obviously, having all of the routine infection prevention and control things in place before you get to the point of having to deal with positive cases is really important, particularly again, if you can imagine if you're in an outbreak setting, your staff is also going to be impacted and you'll be using relief staff. And so having your core staff very well trained and procedures in place already and the residents used to those will make a huge difference. Talked already about testing, but testing early and testing frequently I think is a huge recommendation and lesson learned from this. Having a plan to deal with the results is obviously very important. And then as we learned, having a backup plan is also very important. I think one of the reasons that authorities are reluctant to do the testing is that they're afraid of what's going of the results. And I think the Willowdale situation did lead to that afterwards, perhaps understandably, but having a good solid plan, as much as you can plan ahead of time, can help mitigate some of that reluctance. At the end of the day, though, whether or not there's a plan in place, I think we have a duty to test people because that's the only way one can control the transmission of the outbreak there. And just closing our eyes to it because we don't have a plan to deal with it won't work. But still, if you're sitting where you are now and you are in a moment where you're not in full outbreak, this is the time to really start to think about that. So when we talk about that plan, it's really thinking about the physical space that you have and trying to figure out how you would isolate the sections in the building, remembering that you've got to have access to bathrooms. How are you going to manage meals so that staff and individuals are not crossing over in the sections? If they are crossing over, then they are going to have to, you need to be thinking about changing their protective gear, all their PPE, etc. So really thinking about what you can do in the space and then what you need to do to create the flow that will avoid contamination and maintain the isolation in your sections. And that may mean things like roping things off, using tapes, etc., whatever you need for that. But just having a plan and an idea of what the possibilities are within your physical space. I think it's really important to pre-identify potential healthcare partners. If you are having even a single case, that individual is going to have some healthcare concerns. Having access just to a video call with a healthcare provider can go a long way in reassuring people that they're okay, or can help identify people that do need to be moved out to a higher level of care. In terms of doing the mass screening, there is a huge amount of work for the clinicians on the ground. It really, the swabs are such a small piece of doing the mass screening. It's really the follow-up of the results and being present to deal with people's questions and concerns afterwards. That's really critical. One resource that I had never thought about was that we actually developed a partnership with the paramedics who came, we didn't realize this in the beginning, but for the second round of screening, they came in and offered to help with the screening, but also to give test results, to provide clinical care, which was fantastic, but something we had never thought about, and maybe a resource that's open to you in your communities. Having your communication strategy ready, of course, is really important, and communicating both internally and externally is important. Knowing your stocks and pipelines for PPE is huge. All of those practical issues that I talked about. And then just, again, it's a detail, but having contact information for your residents. If you're able to do that, that can really, really help make a big difference. So this brings me to the end of my rather long-winded presentation. Apologies for that. But what I want to say is that this was perhaps an extreme situation. Everyone got through it, I think, overall with very good results. There were very few hospitalizations. There were no deaths. The wrap-up screening was very positive. We had only one further positive case when we went through our building with negative people. So I think it shows that it was very successful to do the isolation. And the staff were incredibly hardworking and courageous to continue working through all of this. Everyone was pushed far, far out of their comfort zone. But really, I was so impressed with their spirit and the work that they did, as well as that of the residents and the resilience of the residents. It was quite an amazing experience to be part of. I hope other people will not need to go through this, but it does show that it is possible to cohort such a large number of people very quickly, and to do that safely. So now I'll go to all of these questions.
So Leslie, there was one question about, did you say that there was 50% asymptomatic cases? Could you address that?
Yes. Yeah. Interestingly, in the US, some of the studies they've reported in shelters, they've had much lower numbers than that. Something like 8%, 13% with symptoms, and the rest all asymptomatic. So we have to be really aware of that.
Leslie, I think it bears emphasis the fact that of that negative group, only one person tested positive on the repeat testing. How effective the infection prevention and control strategies that were put in place at Willowdale were. I think probably there were a lot of people who sort of held their breath as that repeat testing got done, and like what a testament to how successful the team was on the ground there.
Yeah, exactly. It was very reassuring, and we were holding your breath, as you say. Yeah.
All right, there's another question. How did you handle addiction issues or mental health problems that often result in poor behaviors? Why don't we give this one, we'll let Kate, you want to start with that one?
Yeah, so our peer and community workers have been tremendously helpful in navigating this. Our strategy generally here for substances, particularly around alcohol as one example, is our goal here is to really just meet folks where they're at. It is not, we're not having people enter our facilities because they're interested in decreasing their substance use or changing their substance use. So if people want to continue their substance use at the rate they normally would use at home or at the shelter, wherever they're coming from, we're trying to facilitate that as best we can, which I think for the medical folks in the team sometimes requires a little bit of change in our mindsets. But for example, if someone's drinking 5 beers a day for whatever reason, and they want to continue to drink 5 beers a day, we're working to facilitate that. And that I think has been quite helpful. We're trying to be really creative around strategies if people want to meet their dealers or access the substances that they usually do. We do have opportunities to offer other alternatives. So for example, we've got connection with safer supply prescribers for people that use opioids, but really trying to just sort of facilitate people continuing to do what they would do, and if possible to do in a little bit of in a safer, more supervised or accompanied way, and really relying very, very heavily on the peer team on the ground here and the community health workers on helping with their very skilled de-escalation strategies. And a lot of it is like snacks and Netflix and frequent cigarette breaks. And we have them because the people are in their own room and they're able to get some rest and they have privacy and are pretty comfortable in the setting. I think for some folks, they aren't using as much if they often use to cope with the setting that they're in, which is quite distressing to them. There are some folks who maybe are using more because they're bored. So there's a real mix. Did that sort of answer the question?
Yeah, Leslie, do you have anything to add? I know this is wasn't the cohort at Willowdale, but anything to add?
Yeah, we were fortunate that was not a major problem for us. So.
Maybe Kate, could you speak a little bit about the challenges with isolation facilities for homeless people and keeping people inside and isolated? Can you talk about the strategies to support that type of isolation?
Yeah, can be tricky. It's sort of interesting. I think it's popping up a little bit already because we've got these two sites that are in quite different locations. One is out by the airport, and the second one that's just up and going is downtown. For example, the airport site, so everyone there has COVID. So from a client perspective, it's actually not so complicated because if the clients want to share a cigarette outside or get some sunshine in close proximity, we're less concerned about the risk of them infecting each other than in a site where some people have COVID and some people don't. Having people are going outside accompanied, which helps, but sort of allowing people a bit of space to get outside and get some sunshine and use what they want to use, I think can be quite helpful. I'm also trying to make sure that people have, as Leslie mentioned, like a phone, Wi-Fi, the ability to Skype or FaceTime or reach people that they need to reach really helps. One of the sites that some of the physicians are supporting, like the Wi-Fi is not great, and there's lots of comments about, yeah, the Wi-Fi is crummy, and people have a pretty hard time getting in touch with other folks. I think one of the real advantages of this site, as I mentioned, is because for many people, it's the first time, like they've got nice hot showers, they've got a bed, they're on their own, they have some privacy. The advantages of the fact that it's a pretty comfortable setting. A lot of people are very happy to stay here because it might be a more comfortable setting than the setting that they've come from. And some folks who are symptomatic, like they feel crummy the same as anyone else would want, like a really comfortable place to recover if they've got a bad cold or something not great going on, which is what mild COVID can look like. And so I think if possible in different settings where people are supporting folks with COVID, sort of providing the comforts that are available can go a long ways to helping people stay put. Maybe I'll just add quickly, one thing that has been really important to us is not contributing to the criminalization of homelessness. And so Toronto Public Health has been involved if we have folks who are known to have COVID who leave the site, but really important that we don't want to be policing people, and we're really just trying to support people staying isolated as best as is possible. And ultimately, if someone does not choose to stay at the site, they can take that decision, and public health helps to make sure that they're followed.
Okay, I think I don't see any more questions. Just from my end, I just want to thank Leslie and Kate so much for sharing their experiences. I mean, I've learned a lot, and I think they had challenging experiences, but some good information to share. From our end, from Doctors Without Borders, we are preparing 2 trainings that we would like to distribute to anybody that's interested. So that'll be coming up in the next week or 2 weeks. So the first one is going to be just general infection prevention control measures, specifically on standard precautions, transmission-based precautions, and a focus on specific considerations for COVID, as well as we have a second module that will be coming out, which is specifically about preparing infrastructure on for COVID-related facilities. So if you need to set up an isolation area or an assessment area, how you should do that safely, and we can give just basic guidance and recommendations. So that training will be provided shortly, and we'll provide Tim with those resources once they become available so that he can share them on this network.
Right. Yeah, terrific.
I think there was one question that came in. Did you accept donations for residents to keep them occupied, puzzles, films, or was this discouraged from an IPAC standpoint? Kate?
You know, this is terrible. I actually have no idea because the community teams, like they have this like magical room full of stuff that has been donated that is provided to clients, but I don't totally know. Unfortunately, I don't totally know what's in it. They have been providing clients with lots of different stuff, but I'm not sure specifically about those kinds of items.
Leslie?
Yes, I'm not sure about the things for the puzzles, films, etc. But I know at Homes First they accept a lot of donations, most importantly around PPE, because they'd actually put out a call with all the media attention when it started, and there was also because one of the challenges was this took place during Ramadan and people were starting to fast. Some of them were ill. That made it more, they'd already been planning in terms of the catering, how to accommodate that, but this made it much more difficult for people. They couldn't go out of the building, for example. So there were some quite significant donations of food around Ramadan, which was, I think, was really important for people. And we didn't have any concerns about the IPAC. We didn't isolate the food, or I'm pretty sure they didn't even wipe it down, but it's all fine.
Yeah, I think from the IPAC standpoint in terms of sharing materials and things like that, normally if you're talking about one within a COVID positive setting, sharing amongst COVID positive is probably not a problem because everybody has already been confirmed. I think the challenge is when you have people who are, supposed to be in isolation or they're close contacts or they haven't tested positive. What we really would encourage is really good hand hygiene, cleaning of anything and frequent cleaning. So even if it's bathroom facilities, that they're cleaned more often than they would be before, just in terms of preventing that sort of cross-contamination. So whether or not, if it's a film that people are using as a DVD that can get wiped down in between people, I think that's relatively easy to do. If it's wiping down a book, that's a little bit harder. But then again, research, if you look at how long this virus lives on certain materials, usually it's self-limited to that viability. So, I mean, I think the mental health component and the support towards this population is really important, and whenever we are able to do that or create ways for that to be possible, I think is very key. Okay, I think we are getting very close to that 1 hour mark, so I'll hand it back over to Tim.
Yeah, well, thank you very much to all of you, to Jaime, Leslie, and Keith for joining us today. That was a super helpful, very informative webinar and some great information. I think we'll have a recording of this webinar along with copies of the presentations available and will be posted on the CNH3 website. And we will pass along the other information, and we'll post the other information that Jaime referred to about future trainings with MSF. So with that, thank you very much to our presenters, and thank you very much to everyone who has joined us today, and thank you for your work every day on the ground supporting our homeless neighbors through COVID-19 and hopefully soon to an end to homelessness in Canada. So thank you all very much, and we will see you all soon. Thank you.
Bye, everyone. Bye.